straight leg test, you're just gonna passively kind of go up here, basically ask them when they feel pain or whatever. Shooting is kind of like for sciatica or sciatic nerve pain, go through the leg. So if you don't find pain, like 70 degrees, I think is what the normal is. And then if he has pain, okay, so for the straight leg test, basically you're gonna just go up, passively bring his leg up until he kind of feels pain. Ask him if he feels pain, he says yeah. Lower it down, just kind of slightly this way, straight away. And then either dorsiflex the foot this way, and it should recreate those same symptoms because you're putting tension on the nerve. Or you do the same thing, pick his head up, just to basically put tension on that nerve.
That's for sciatic pain, you said?
Yeah, so basically either irritate sciatic nerve. Then the next same thing, basically same principle, is the bowstring test. Do the same thing, go up until you feel pain, bend the knee a little bit, and then just basically put tension on the back of the, like the hamstring muscles. Basically try to. Yeah.
Bowstring cramp
test. I can't remember what the other name for it is, but
cramp.
That is. And basically just pushing on that and the nerves and stuff back there to recreate that tension that you had just had before. Piriformis test. Basically just doing external rotation of the hip. Basically trying to create that tension around the piriformis that goes to the obturator nerve that goes through it. Basically trying to, if that's tight, you're going to pinch the nerve, which is going to cause numbness, tingling, pain going into the leg.
So
most likely the groin.
Thing for like the sciatic pain, or
so this one's more for like obturator nerve.
okay.
What's it called? Pinched due to tight piriformis muscle. Gamslins. While you're in this position with Fabers, basically cross here, put your hand on the opposite hip, and just push down here. Basically trying to recreate SI joint pain. When you're doing this, the SI joint, you got the sacrum and the ilium, or what's the ilium? Huh? Fabers. Remember, it's flexion, abduction, and external rotation. That's what's short.
Flexion of the hip, abduction, and the external rotation.
Yeah. And then you're just holding down the opposite side of the hip and pushing down, and you're causing compression of the SI joint, so they're gonna get pain. Another one you do is a compression test. So basically find the hip here, the iliac crest, ASIS area. You're just gonna push out, and basically you're pushing out here, but it's causing the back wings of the SI joint to push together, causing pain. Goes through if you lay on your side, roll that way. Do the same thing, push down here and cause pain, kind of pushing down into the joint. And then the same thing is if you roll on your stomach, you can just palpate the joint straight down, straight on, and elicit pain. Those are all kind of things for SI joint pain. Another one for SI, if you roll over on your back, slide over the edge of the table. Basically, extend his hip, hold back here, Ganslin's test. Basically trying to elicit pain through the SI joint. You can also do it with the laying on their side, this way, and just pull back. Pull back to extension, whatever most comfortable for you guys. What else is there? Yeah. Huh? You can do it that way. I've seen it done just like basically creating the tension off the hip flexor and whatnot. I guess we'll go to the knee.
You do Trendelenburg.
Yeah, Trendelenburg. So
So what's standing?
this one's looking for glute med weakness. So basically,
This is my butt.
basically just gonna stand, like a single leg stance, looking for the hip to drop this way. Trendelenburg.
This is like a little exaggerated, but say I was to like tilt my hips this way, it'll show like I have glute medius weakness.
So for this one, you think you're looking at this hip, but you're actually testing this hip. Because if this is weak, that means it's going this way. You're not being able to hold yourself straight.
And then same for the opposite.
You're looking for it to dip this way.
Good. That's one of the main ones.
That's a good functional one.
This is
glute medius weakness.
So it's the not the effective leg, the
It's
unaffected
a
leg.
stance one.
Standing one.
Standing one. That's the one that you're testing.
Yeah. So the way you're gonna, if you're sitting this way and you're leaning this way,
Right.
this side is gonna be the weak side. If you think about it, this is not pulling, your hips are gonna go this way because this is not really doing any. No. Okay, so for me, usually I start by doing like all the range of motions and everything, you know, flexion, and extension, then you do muscle testing. So I'd have them sit off the edge of the table, basically have them kick into my hand, do test strength of the quads, have them pull where the hamstrings. First one, we'll do lock bends, basically just kind of get them to like a 20-30 degree angle, have him relax. If he can't relax, you can have him close his eyes. One thing, there's a Jendrassic maneuver. Basically, you can hold his hands like this, close his eyes, and you're pulling there. Try to take like your mind off of everything, kind of relax. Basically, just try to do like anterior, translate a slight anterior translation. If you don't have an ACL tear, you're probably not going to feel much, just because it's doing its job. If you do have an ACL tear, it's just gonna shift and you'll feel go whoop. It actually makes that sound. Okay. Anterior drawer, same principle. Basically, you're gonna sit on the foot so it stabilizes it. And you're just gonna pull forward, looking for anterior translation. For this one, if you have a PCL tear, you could mimic passive anterior drawer test, just because if it's already sitting back farther, and you're pulling forward, it can mimic it. So you really gotta feel for that sudden stop up top, and kind of not solely look at the movement itself.
What's that assessing?
Anterior, the ACL.
Okay.
So the PCL, for testing a PCL, 2 tests. The opposite of the anterior drawer, so the posterior drawer, you're just pushing backwards, basically looking for that translation and feeling for that sudden stop. Another one, you can do the sag test. So he's gonna bend his knees, this, and you're basically looking for them to be kind of congruent. And if it's one's dropping lower than the other, you can tell it's, the PCL is not doing its job. Make sense?
There's a comment about the lockments in the anterior drawer, like Dr. Maserati was saying. A lot of people prefer the lockments versus the anterior drawer just because so much guarding involved with the anterior drawer. People still do it just because it's like a known test for ACL. So I think a lot of people prefer the lockments over
for testing purposes. The gold standard-ish is the lockments test. So
which one is the lockman?
that's the one where you're here.
Is that just for ACL?
Yeah.
ACL.
And you can do the
you
same.
get PCL, but no one tends to do that one.
Yeah. You could do it where you put your knee under there to really support it if you need to. If you can't get a good grip on them, if they're bigger, whatnot.
So the lockmans you grabbing the tibia.
So yeah, so you're grabbing the femur here, basically doing a posterior force down this way, grabbing the back of the tibia, and you're doing anterior. So you're basically going here, trying to stabilize the femur and pull the tibia anteriorly. Okay. And there's McMurray's, basically. No one uses this test because it sucks. Feeling for popping, clicking. Basically, while you're doing flexion, you're rotating the tibia on the.
When you do that, are you physically feeling for the popping, or are you eliciting the feeling of popping from the patient?
This one's kind of subjective. It's more feeling for they're feeling for clicking and popping. Sometimes you can hear it. I've heard it a few times, but that's only on really large tears. But most of the time it's just painful, no matter what. Like if you have any interarticular injury, it's gonna be pain just that flexion and extension alone, rather not even. So that's why it's kind of not a great a sensitive test.
Can you do it again? Just
Will you explain what you're doing with your hands?
Yeah. So basically, while I'm going in, I'm rotating here and pushing like what's called a valgus force, and then I'm going out. I'm doing the same thing, rotating and doing a varus force. Yeah. So I'm rotating the tibia on the surface there. So trying to elicit if there is a tear, it to kind of flap up, and you're irritating it, and we're kind of going there.
So that would be like medial versus lateral meniscus.
Yeah. Kind of. I guess. Yeah.
That's what it says.
Yeah. Yeah.
And this is called McMurray's.
McMurray's. And then another one for, well, I was gonna say, there's a functional test you could kind of do that, like a screening test called a duck walk test. Basically, you get deep squat and you just have them walk.
Can you walk for us?
No.
What about the crab walk?
The crowd.
Can you quack when you do that?
No, I can't. I'm allergic to quacking. Okay, now, Apley's.
Medial lateral grind. This one.
Rotate. Yeah, you can do the grind one. Yeah, it's just doing the same principle as McMurray's. You're just kind of putting them in deflection and just kind of grinding it back and forth.
Internal rotation.
Huh? I just told the grind.
Yeah,
test,
medial lateral grind test.
And there's Apley's.
That's for meniscus as well.
Meniscus, yeah. It's a great test.
It's like a grind test.
Right.
Yeah.
Apley's.
Not many of the meniscus tests are really that like specific or
No, not
sensitive.
really.
A lot of them you're gonna
It's
have
why-
to look at mechanism of injury and the clicking, popping. That's gonna be a bigger indicator. So you got Apley's distraction. So you're basically pulling up. It should alleviate pain. Pull up. You can twist this way. You know, think about it. You're pulling away from the joint, so you're not any loose parts on the tibia aren't going to be rubbing and crunching, so that should feel better. Then you got Apley's compression, and you're doing the same thing, pushing down and rotating, so you're crushing in there and rotating, you know, causing it to be irritated, and if there's a flap or anything, causing it to like flick up and elicit pain. Okay, and then roll back up.
You do the compression.
Yes, sir. Compression and then distraction. Pull up. Do the same thing. And then for MCL and LCL, do valgus. Basically pushing in. So if you think, here's the two parts. Here's the tibia, femur, and you're pushing this way. You're going to cause it to open up on this side of the. Do it
So
in.
that's testing NCL.
Yeah, so you do it at 0, like full extension you can do, and then a little bit at 30 degrees extension, or flexion, I mean. And the same thing.
You can see it at 30 degrees, right? Because then the
You isolate the MCL, yeah.
Yeah.
But we've always been taught, because I know he mentioned that, Maserati mentioned just do it at 30 degrees, but we were taught to do it at 0, because you can also involve the other structures, like the PCL. If you cause pain quickly with that one, or pain with that one, then
Yeah.
it's indicative of more structures are involved.
And with both these, you're looking for gapping, so you're really going to, like if they have a MCL sprain or tear, like a grade 3 sprain, it's really going to open up and it's just going to be all loosey-goosey and you'll really see it. And then same thing with a varus, basically. Easier. You can do this, just same thing, just kind of push out, testing the LCL. Really just trying to open that joint up, see if it's moving. What else do we got on that list? Instead of all the ones I do for the knee.
Varus, valgus test.
Varus valgus
Varus
test.
for lateral.
Valgus
MCL.
stress, varus stress test. That milking one I was taught but never done before.
Oh, I'll do the convolution one.
Are you talking about the one where you push down and then have them contract the
Yeah.
quad? Oh, that one's awful.
Yeah.
So basically, I just have them basically milk down the patella and then have them contract the squad while you're kind of pushing there, and it forces the underside of the patella to have to grind into the groove, causing pain. But that one's
usually
not,
it causes pain like
I was
on
gonna
anyone.
say, that one's sensitive because just about everyone gets pain unless you really have you haven't done anything. But
Ever.
Ever.
And that's for patellar? pain?
Chondromalacia.
Oh, chondromalacia.
That's when the cartilage under the patella gets degenerated or just
Yeah.
from overuse.
Okay.
So you're just having that grinding feeling.
So that's for all the
Pretty sure I
patella
have
ones. For all the stents.
I guess one of the patella ones just lateral medial glides, kind of just testing for the retinaculum movement. So there's the retinaculums that are holding this, like over here, this way.
We're having an ortho meeting.
So basically testing whether or not the retinaculum are intact. So potential like patellar dislocation or subluxation. You can kind of, if that's really loose. That one's kind of tough if people, they're not relaxed. The quad will just engage and you won't be able to get good movement if they're not relaxed.
Do you have any questions? That's really the basic ones that we actually practice and like use.
The ones I use primarily if I like suspect a knee injury, Lockman's, anterior drawer, sag, posterior drawer, valgus varus.
I do McMurray's.
I'll do McMurray's, yeah, but it's, you know, I usually use the rest of my like history and everything to really kind of.
The valgus varus test that you're like moving his leg and rotating it, like,
Yeah, the
how does
McMurray's.
it differ from the one where you're just stationary and pushing?
Oh, McMurray's for
Okay,
meniscus.
yes, that one.
Uh-huh.
So that when you're flexing it and rotating it, you really, the main thing is rotating the tibia onto the femur, so it's going there and causing the irritation of the meniscus. Where that one's the valgus varus, you're just testing the stability of the medial and the lateral collateral ligaments.
This is pretty interesting. A football player had a grade 3 MCL sprain, so he was very relaxed and like we had translation, but no pain at all. Like, once it's like completely torn,
That's the way a lot of it.
so it was kind of hit. I was like, oh, so I never knew that. Usually, they're like screaming pain, but it was completely torn, so you don't elicit any pain. So
It's kind of the same
I
with
thought that was an interesting finding. I was like,
AC joint separations. Like
ACL.
like if you have like grades 1 and 2, well 2 is more painful than 1, but 3 is usually the least pain or usually painless, except for that initial, you know, you follow it, snaps, but then after that subsides, it's usually pretty painless because you tear all the nerve endings and whatnot, and there's nothing left to.
And usually it's really hard. Like, say if it's like a day after someone tore the ACL, just have so much swelling, and then they're gonna start guarding.
Yeah.
So
So that's why like the
it's
first
really
test
hard
usually
yeah.
like wouldn't as soon as possible. Like so, I don't know, for us it really doesn't like for us being on the sideline and stuff. Like our first test would be the Lockman test, just because it's you only have such a short window before swelling comes in, and guarding and pain and stuff causes people to not want you to move it.
Yeah.
But, yeah. Any questions on lower?
So Lockman's would be the first test that when there's an injury during the game. That
Yeah, if you suspect any knee, usually that's kind of.
And you can kind of spot it, like once you like you watch TV, you try to look for it. You can like see the trainer go out and try to test it on. Yeah,
Yeah.
soccer's big.
How long after the initial injury, like you can test it right away if you're on the sidelines, but how long have you found the swelling to persist before you can get them in the room? Like if they come to your office,
Yeah, yeah.
Is it 3 days, 2 days, a week?
Yeah.
I'd say so.
Yeah,
Yeah.
it's.
But
it
we have a lot of
blows up.
resources that can
Yeah.
reduce the swelling.
If
so
you don't
I've
do
never-
anything for
yeah.
the swelling, then it'll persist and it won't go away. It'll blow up and be like a fat balloon. But yeah, if you typical like rice type stuff, it'll usually go down and you'll be able to manage it. Another one I thought of. Roll on your side. Ober's test.
Oh yeah.
It's a good one for runners. Basically, relax. You're gonna flex, abduct. You got a tight IT band. You're looking for the IT band the knee should relax. Just kind of should drop down here, below, parallel to the body. But if it gets stuck up here, it means the IT band's tight. You really just flexion, abduction, and then just hold them up here, looking for the thing to drop. And that's just, if the IT band gets tight, the TFL and the IT band there, it crosses both these joints. If that's tight, you can cause irritation over the lateral side of the, of the tibia and the femur. And then you'll get that like runner's knee, IT band syndrome.
Was there one where they were pushing it down below the edge of the table or something from one of our videos? Or...
It's probably gains.
Yeah, probably Kansas.
Oh yeah, I did that.
Yeah, you're laying on your back.
We can do it again.
Yeah, so,
You got this one?
yeah, I was trying to not stand in front of the.
Yeah, it's for
SI.
SI.
I was trying to stand in front of them. Yeah,
Yeah.
so that, and you're basically just pulling here. You can also do it where he holds on to his, grab this knee, bring it to your chest. And you can also do it where you're off the side of the table. Don't fall. And you basically, I don't want to be in the camera,
Oh, you're
but
fine.
basically the same thing, stabilizing him so he doesn't fall off and pulling backwards. All
And what's
kind
that testing for?
of SI dysfunction. It's kind of a garbage term, but yeah. Yeah, that one you're just usually looking for eliciting pain.
Oh, Kerner-Brudzinski.
I never used.
Kerner-Brudzinski is just for like nerve root impingement or meningeal irritation.
Yeah, that one. Yeah.
So this is Kernig. He's the one who invented this part. So it's this neck flexion. Then Brudzinski is coming up. That will cause irritation, nerve root impingement, or pain.
Yeah, that's meningeal.
Paresthesia, yeah.
And you do that passively, have them relax, and you do the lift.
That's not a big one, I guess.
We learned that for meningitis, right?
Yeah, for meningeal irritation, meningitis.
Yeah,
Yeah. Then I guess Brzezinski added the knee factor into it, so now it can be like a nerve root impingement type of test as well.
Would the pain, if you did that, if the pain's lower back,
It'd be in the
then you're
lumbar
talking
area.
nerve root
Yeah.
stuff.
Will actually hurt me.
Spinal tap.
So that's all the knee ones. We can do upper extremity now. You just want.